Hi, everybody. My name is Prachi Bakarania, one of the scoliosis and spine PTs here at NYP Columbia. We are so excited for you to be here today. I'm going to just share my screen. So we are very, very fortunate to have a talk on pelvic floor dysfunction in our patient with scoliosis. We're extremely fortunate that today we have Dr. Farah Hameed. She is one of our rehab medicine physicians here at Columbia who specializes in women's health. She is my go-to for scoliosis and women's health. She's a wonderful speaker. I think we're going to learn a lot from her. And then we also have Dr. Laura Glazebrook, who is tremendous in this space. She speaks all over the country, specializing in scoliosis, physical therapy, and pelvic health. Just a little bit of housekeeping. For anyone, please ask questions. We're going to use that little Q&A box at the bottom. Whenever questions come to mind, don't wait till the end. We'll be moderating them at the end. And then just just mark this on your calendar, April 7th, which is a Monday, we have our next webinar scheduled, and it's going to be surrounding the importance of bone health in the developing child and scoliosis. We're going to have Dr. Eileen Fenoy. She is an endocrinologist here at Columbia, and Dr. Kristen Russo, who is an orthopedic surgeon, talking about it. Dr. Vitale is going to be moderating it, so you definitely don't want to miss that. Today, we've introduced our speakers. Dr. Hameed is going to briefly go over some pelvic floor anatomy, which is like a whole course in itself. So hopefully it'll just spark some interest. And then Dr. Glazebrook is going to talk about the role of the pelvic floor PT as a scoliosis PT. I always want to know, when should I refer out to a specialist? And then we're going to talk briefly about some medical interventions that are available for this patient population. So I'm going to stop my sharing and I'm going to pass on the baton to Dr. Hameed.
Hello, everyone. Thank you so much for joining. I'm very excited to be here today. I think we'll sort of be going over two different chunks here of sorry, hold on one second as I'm sharing my screen. Hopefully this pops up. Sorry, my computer's being very slow, but I'm very excited to talk to you a little bit about just introducing the pelvic floor and sort of thinking about scoliosis with that. I have about 10 minutes. I'm going to go quickly because there's just a lot that I want to get through and talk to you about. So hopefully it's not too quick. I know this will be recorded and slides should be available through as well. So you can always look back to reference. And so in terms of objectives, we're going to sort of do a few things today. We are going to talk a little bit about sort of the pelvic floor, associated musculature, connective tissue that can impact pain. So sort of things to look out for. I'll talk briefly about just a history and physical exam for scoliosis that I do and sort of thinking a little bit about the pelvic floor in that as well. And then just try to tie that together, right? What is the connection between scoliosis and pelvic floor dysfunction, and try to sort of see if we can connect the dots here. So let's see. Hold on. Okay, so let's talk about the bony pelvis first, right? Obviously, most of you are probably pretty familiar. We have the lower lumbar sort of segments here, this sort of sacral area here, and then, of course, as they meet the iliac crest, where we have the sacroiliac joints in the back, those sort of two bones come together to the front to the pubic symphysis, and of course, sort of all of these areas here, whether it's the lumbar spine, those sacroiliac joints, the pubic symphysis, could potentially be sort of pain generators. Of course, we also have the hip joint, sort of as pictured here. We have ligaments that sort of support the spine and pelvis as well. So the anterior sacroiliac ligaments here, some of the sort of lumbar ligaments here as well, the ligaments that sort of support in the front of the pubic symphysis that can kind of get overstretched with things like pregnancy, for example. And then the posterior sort of pelvis here, a lot of pain generating potential ligaments here, including the iliolumbar ligament, the posterior sacroiliac ligaments, the sacrospinous and sacrotuberous ligaments, important nerve structures that run through there as well. And so all of these are sort of important ligaments to kind of know and be aware of when we're thinking about the pelvic. region. Thinking about the pelvic floor specifically, now we have sort of one of our main muscle groups, the levator ani, which has sort of three different muscle groups that sort of go into that. And so this is obviously the anterior portion of the pelvis here and sort of the posterior portion of the pelvis and tailbone here. And so you can sort of see these different layers of muscle. So the puborectalis, the pubococcygeus, and then the iliococcygeus here. And those are sort of the three muscles that make up that levator ani group. This is sort of a opposite view here where the posterior sort of pelvis is sort of here in the tailbone and the anterior pelvis is here. And deeper to that, we have a couple other muscles you're probably familiar with, including your piriformis muscle, which you can sort of see here in relation to those levator ani muscles, and then the obturator internus muscle here as well, another one of those muscles that we can sort of palpate on a pelvic floor exam. So those are sort of the main muscle groups and things that we're going to be looking for during an internal exam. And we also want to think about those nerves of the pelvis. I know I sort of briefly alluded to some of those. We obviously have the lumbosacral plexus. We have the pudendal nerve. That is a very important nerve. You can sort of see it pictured over here where it's sort of exiting through Alcock's canal and then sort of going and dividing into the inferior rectal nerve, the perineal division, and then the dorsal clitoral nerve as well. And so that's going to give you a lot of sensation sort of around the sort of vulvar region as well as the perineum and sort of even posterior towards the rectus area. So, we want to sort of think about that as well in terms of potential pain generators. We also have really important nerves that live in the abdominal area. So we're sort of going to briefly kind of go over some of those. So here it's sort of a little bit more of a simple schematic where you have the iliohypogastric and ilioinguinal nerve, which sort of run over here. That can give you sort of lower abdominal wall or sort of even groin pain. And then sort of further down over here, you have the genitofemoral nerve, which sort of breaks out into two branches here, more sort of groin related pain that can come from that. And obviously here you can sort of see how closely, those nerves are related to some of the muscles as well as some of the big blood vessels and things when we're thinking about interventions in the talk that we'll do next. And so when we're thinking about where sort of the overlap for some of this cutaneous innervation comes from when we're thinking about these nerves, I think hopefully this picture is pretty helpful in terms of when we're thinking about a neurogenic process and sort of thinking about a neuropathic pain, where that might present. So here is sort of outlined. A is sort of the genitofemoral nerve. B is sort of more of that inner thigh groin region with the obturator nerve. Sort of now posterior buttock and sort of lateral perineal region is your inferior cuneal nerve. The pudendal nerve is sort of this whole area here. And then sort of more sort of less deep into that sort of labial region here, you have your ilioinguinal nerve. So that's going to be a little bit more groin and less sort of going now down posteriorly a little bit less. And then this is going to be your perineal branch as well. So those are sort of main nerves and sort of thinking about a lot of that overlap and crossover in terms of where that might present. Of course, this is not going to be perfect for everybody, but hopefully a little bit of helpful representation of sort of the overlap and the areas where, some of these nerves, when they get entrapped or when they get painful, where they can present. So when we think about pelvic pain, actually, when we look at sort of sources of that, only about 12% are purely musculoskeletal in nature. And so what we'll sort of see is that there's a lot of overlap and a lot of sort of, other reasons other than the musculoskeletal system in terms of having pain in this region. That includes gastrointestinal issues, genital urinary issues, as well as, gynecologic or reproductive issues. So there's a lot of different sort of structures there and a lot of different sources of pain. We'll sort of talk about that a little bit further when I go over the different interventions that are possible for this. But just remember, there's a lot of different things happening here. And so it does get complicated. And I think just being aware of it, I think is the most important thing. So when we think specifically about the pelvic floor, all those different muscles that I sort of talked you through, what is the function of that, right? It's the bottom of our core. It really helps to sort of control and support all of those important lower abdominal and pelvic structures, including your bladder, for females, uterus, the rectum as well. And so obviously it can help, those muscles help to sort of control our ability to void and defecate as well. Obviously, it helps to support continence of both both, bladder and fecal incontinence. It also can sort of, control things like, constipation can sort of sometimes come from the pelvic floor because if those muscles are not able to relax, you're not able to actually have a bowel movement or even urinate. So it can also present as urinary retention. And of course, most importantly, it supports pregnancy. And so that's where a lot of dysfunction can sort of come from around that time of pregnancy or postpartum. Also helps with sexual appreciation as well. So sort of another thing that we might screen for in terms of when we're evaluating the pelvic floor. And what does pelvic floor dysfunction present as? So this is sort of a nice schematic here where it basically shows you all the different places pelvic floor dysfunction can show up at. So low back pain, it can show as hip pain, it can show up as buttock pain and groin pain, thigh pain. We talked a lot about all those different muscles and those nerves and the innervation. So all of these sort of different areas can be where people will complain of discomfort. And so I think when we're seeing a scoliosis population, you're very likely potentially going to see some of this right back, hip, buttock, very common complaints for that. And so thinking about the pelvic floor in relation to the other joints and the spine, et cetera, I think is important because, of course, there's such tremendous overlap. And so when we're thinking about specifically screening for and thinking about a history, I think we really want to make sure that we're asking the right types of questions. So I think I'm not going to go over everything, but really looking at the GI sort of system, we're looking at the gynecologic system, the GU system, as well as actually even things like anxiety, depression, or, sort of trauma to, the area or trauma just in general can present actually with pelvic floor symptoms. And really, if we're finding two or more of these as positive, that's really when I think we really need to be looking at the pelvic floor because, again, there's very likely a potential overlap here, and we don't want to miss sort of screening in somebody that might have pelvic floor dysfunction because a lot of the times if you treat them without that, you're not going to necessarily get improvement. And so specifically, I think, one of the things that we're sort of looking at here, sort of trying to piece together, is there a link between scoliosis and pelvic floor dysfunction, and what could that link be? And so, I think in clinic, my answer would be very big, probably yes, likely. But when you start looking at the literature, it kind of starts fading a little bit, maybe, perhaps, possibly, because there's just not a lot of actual scientific proof that I can sort of show you today. But there's a little bit. And so I think we'll sort of piece through that next. So when we're thinking about, scoliosis, we're thinking about those fundamentals, right? Just when I see a patient in clinic, even just standing there, right, we can sort of see a lot of asymmetries that are happening, right? Either at the shoulder, the scapula, the spine, obviously the ribs, the pelvis. You can even have uneven leg length. So all of these things are things that we're going to kind of look for and screen quickly when we're sort of evaluating. And you can actually sometimes, a lot of the time, see these, things sort of pop out. And I think when we think about some of the scoliosis-based physical therapy interventions, like the Schroth therapy method, where they're sort of, a lot of the physical therapists are really looking at these different movement patterns that are developing because of these different blocked areas of throughout the spine and hip and pelvis. We want to be able to kind of assess for that and think of that. And if we think about that sort of muscle dysfunction that happens along the spine, of course, because the pelvis is such an important piece of that, we want to really think about the pelvis and the pelvic floor as well as sort of part of that. Because remember, it's the bottom of our core. And when we're thinking about an adult scoliosis history, sort of thinking outside of just the physical exam, obviously a lot of the patients that come to see me have some sort of pain. So of course, I'm going to assess for that, asking for all of the important questions here on the left. But we also want to get a little bit of information on the curve. Generally, I'm seeing more adults than kids with this. So, when were they diagnosed? How are they treated? When was the last imaging? What was their, have they noticed any change in their curve? Is there a strong family history? All of that can be really helpful. And I would sort of argue that just like you would probably ask about, sort of review systems wise, ask about any breathing difficulties or neurologic symptoms, I would really ask, potentially some pelvic floor symptoms as well, right? You can simply screen some of this area of, some of these questions about pelvic floor dysfunction by asking, are you having any issues with urination, with constipation, with pain with sex, for example? And those sorts of questions actually can kind of clue you in pretty quickly that, hey, even if I'm not going to evaluate or treat the pelvic floor, there may be something happening here. And then, of course, referring is needed. Obviously, for scoliosis, just in terms of physical exam, we are going to sort of, use a lot of the times this Adams forward bend test, which is a very simple test. I'm sure you're all familiar where we're looking for on forward bending any sort of deformity, either at the ribs or the spine, that may be related to the scoliosis there. We also want to make sure that we're doing, sort of a good neurologic exam, checking for strength sensations, reflexes, including abdominal reflexes, looking for any upper motor neuron signs, evaluating their gait, including tandem gait, looking at posture, proprioception, evaluating for things like the leg length discrepancy we talked about. I obviously think, just quickly looking at the skin, looking for any other systemic sort of involvement that you might want to be looking for. The Beighton score can be really helpful looking for hypermobility, which I'm going to sort of talk a little bit about as well. This is where you can sort of use sort of looking for hyperflexibility at either the pinky, the thumb, the elbow, the knee, and sort of putting their hands on their floor. And you can actually get a score to kind of say if this person is hypermobile or not. And then, of course, generally, I'm not doing pelvic floor exam on everybody, but if they do screen, sort of positive for some of those symptoms that we talked about, potentially doing a pelvic floor exam might be helpful depending on that. And so let's sort of think through, scoliosis and how that pelvic floor can be, sort of involved. And so when I think, of scoliosis, obviously we know this is not a two-dimensional, but this is a three-dimensional curve, right? There's a rotational component. There's a lot of different things that are happening throughout. And so when you have that hip and pelvis asymmetry, right, you can imagine how then you might be loading and sort of increasing shear forces along the different joints, along the muscles, stressing or sort of overstretching different ligaments. And so, of course, things like nerve entrapments can happen. Trigger points in myofascial pain can develop of the pelvic floor. You can get, entrapment of the nerves based on sort of sitting position, even between some of the ligaments of the pelvis. And so all of those different sort of asymmetries that are happening in the spine are absolutely affecting the pelvis. And of course, we want to really be able to sort of think about that pelvic floor in terms of evaluation. I also wanted to talk briefly about hypermobility and scoliosis because I think there is, tremendous potential overlap here. And the reason for that is we know, and we'll sort of talk a little bit about the literature for hypermobility in the pelvic floor, but when you are hypermobile, there are sort of increased risk for pelvic floor disorders as well. And so these are a couple of smaller studies. These are not huge studies, both looking at, so here on the left, looking at kids actually with scoliosis and what percentage had hypermobility. And in that sort of group of scoliotic patients, about 51% had hypermobility. So we know that there's a connection here. When they look specifically in hypermobile Ehlers-Danlos syndrome, in this smaller study here, where they had about 28 patients, they found up to 29% of those had scoliosis. So again, a lot more overlap in terms of scoliosis and hypermobility. Generally speaking, we should be seeing up to 3% of the population with scoliosis at most. So that link of that hypermobility and that scoliosis, I think, is certainly there. Hasn't been very well teased out in the literature, but I think there's certainly something I see in clinic for sure. And as I alluded to, there is this connection as well with hypermobility and the pelvic floor. So I think, when we think about what that can be coming from, obviously hypermobility affects our collagen. Collagen sort of helps with our sort of muscle strength and support. And so when we think about some of the stretching of the muscles over sort of stretching of the ligaments as well around the pelvis, because of that hypermobility, those pelvic floor muscles get overly worked. They get tense, they get tight, they become painful. And so there's certainly a link between here when they sort of looked at patients with chronic myofascial pain, with hypermobility, that they're much higher likelihood of having, pain with sex, low back pain, incontinence, IBS sorts of symptoms, hip pains, than not. And then, of course, the other thing that we sort of see is, a higher risk of pelvic organ prolapse in women with hypermobility. And so again, sort of telling us that those pelvic floor muscles are just not able to support us in the way that we need to. And when we try to look at that connection between the scoliosis and the pelvic floor, I will say that's not as much of a direct sort of amount of evidence that I can show you here. But they did look, I found a couple of studies where they looked in a pelvic pain cohort of about 60 patients at 36% who were referred for pelvic pain had scoliosis in this one study. Another smaller study found about 7% of those that were coming in for pelvic floor physical therapy had scoliosis. So again, higher than that general population of about 3% that we, would sort of see in terms of just seeing general scoliosis anywhere else. And so I think, certainly there's a link here and maybe not so well explored in the literature, but I can say specifically in my clinic, I do see that quite a bit. And so I think always, kind of be thinking about that. And so this is just sort of, that sort of Venn diagram here where we're thinking about, scoliosis and pelvic floor, certainly scoliosis and hypermobility. And when you have sort of both of those, I would really sort of think about, these folks here in the middle that might have all three. And so really, again, screening for and/or referring when needed is important. So let's put it all together. So I think, certainly, hopefully I've shown you today that scoliosis can exist with overlapping pelvic floor dysfunction. And I think really an important piece is evaluation and screening for this pelvic floor dysfunction so that we can really fully assess these patients and treat these women. And looking for specifically urinary, bowel, and sexual function can be helpful in terms of that screening. The other time I would sort of think about it is if you're working on their low back or their hip and you're not really getting, sort of that result that you're hoping for, you're getting more suboptimal results, that might be a good time also to kind of think about the pelvic floor. And certainly, as you're going to hear from colleagues today, having, somebody like Laura, who is both a women's health and sort of scoliosis expert, can be very, very helpful to have in your toolbox to refer, because of course they can really assess the patient as a whole. So that is it for me for right now. I'm going to be coming back. I'm going to stop my screen share. Hopefully I didn't go too far over.
That was amazing. Thank you so much, Dr. Hameed. We'll hear from Dr. Hameed in a little bit. I'm going to pass the microphone on to Laura, who's going to talk about the role that pelvic floor PTs and a scoliosis spine PT can definitely help and play in this space. So thanks again, Laura.
Absolutely. I love Dr. Hameed's talk. You'll find, I was just listening to her talk. There is a bit of overlap in what we talked about. So I will kind of breeze through some of the things, but I do bring a different perspective as a physical therapist versus a physician. So I hope to bring a little bit of context to the therapists and other allied professionals that are joining. So can you hear me okay? Let me share my screen here. I'm going to talk a little bit more about the scoliosis and pelvic floor connection, why we should be screening, what that looks like, and a little bit more into the function of the pelvic floor. So just a little bit about me. I'm Dr. Laura Glazebrook. I have a severe scoliosis. I was diagnosed with early onset scoliosis and then had my fusion at 11. I got my undergrad in exercise science from Kennesaw State University, and I've had my doctorate of PT since about 2012. I've been working in pelvic health approximately 8 years, and been working in scoliosis care about 4. I had to go back and look. I've trained with some of the amazing colleagues through the Columbia system. So, and I also, I do my own scoliosis exercises daily. I've been certified in Rigo Concept Advanced Level 3 and SEAS, which is the Italian School Level 1. I work full-time at a lovely clinic called Align Physical Therapy in Metro Atlanta, and I do both scoliosis care and also pelvic health conditions. Yeah. Okay, so I was asked to talk a little bit about the social media connection. I think one of the things that I've found just looking into just working with patients of all different ages, people don't really go to Google anymore for their information necessarily. A lot of people, particularly in the younger demographics, they're actually searching on social media. So I think different age groups are doing, different platforms. So a lot of times, parents and some of the older people are sometimes looking at Facebook groups or Instagram. Some of the younger, like the Gen Alphas, the Gen Zs are looking at TikTok, Instagram. So I think that it's important for us as providers to be aware of that and to be creating quality content on these topics. Because just like Google, it can be tricky to ascertain what sources are good and what sources are not. So the benefits of social media is it's very accessible to most people. The short form content, like the posts, the little informational reels, they're usually easily digestible for most people. It's also a great way for fellow scoliosis patients and families to find a community, which can be really helpful. in my own scoliosis journey, I didn't know anybody with scoliosis, certainly nobody with spinal fusion until I was in my 20s. So it was very isolating. So the downfalls of social media, as I mentioned, it can be difficult to discern which sources are trustworthy. So it's important to be able to train our patients, families on how to search responsibly. Because as you may know, anyone can create content and garner a large audience, whether they have credentials or not. So that's just something to think about. It's also difficult to provide nuance, which can be tricky for people. As we all know, scoliosis is complex and individualized, and we can't make assumptions, or it's not usually as easy as a black and white answer. So another thing that I always try to put on anything I post is that I cannot provide specific advice. So I put a disclaimer on everything that this is not medical advice, that you should find somebody in person to treat you and to do any diagnosis and to find. I have links to directories for physicians and therapists who are trained in these methods. And as always, it does not replace in-person assessment. So that's important for them to know. So if you're on Instagram, come find me at laura.g.dpt. Love to have you. So I just wanted to put a little bit of a guide as to what we're going to be spending our time with. So since Dr. Hameed did such an amazing job on the pelvic floor, I'll kind of breeze through that first section, although I do approach it from a slightly different angle. We'll talk a little bit more about how to assess and screen for pelvic floor dysfunction and when to refer out. And I was also asked to talk a little bit more about the thoracolumbar scoliosis and the pelvic floor. So I did a little deep dive into the current research that's available. And spoiler alert, as Dr. Hameed mentioned, there's not a whole lot yet. Maybe we as a community can work on that. So here we go. So the pelvic floor muscles, as an overview, they are these three levels Dr. Hameed talked about already. They act like a sling. I have this lovely little model in the clinic. It shows them they look like a little hammock, and they support our pelvic organs. We can contract them voluntarily or volitionally, but they also activate automatically. I think one other thing to point out is a lot of people aren't even aware that there are muscles in this area. So I've treated men, women, people of all genders who have said, wait, I have pelvic floor muscles. Of course, we have pelvic floor muscles. If we didn't, we couldn't hold in our pee or poop. We wouldn't be able to make any intra-abdominal pressure. We wouldn't be able to have pleasant sexual experiences. We likely wouldn't even be able to stand upright. I think the key is if your pelvic floor muscles are doing their job, you likely aren't aware of them working at all. And so Dr. Hameed already talked a little bit about the distinct layers. So all three layers have slightly different functions. Outermost layer is sexual pleasure and climax. Middle layer is known mostly for the sphincters, so holding in our pee, poop, and gas when we don't want them to come out. Then that innermost layer functions with our core muscles and helps to support all of those organs. I did want to speak a little bit about the fact that we do all have the same muscles. They're just oriented slightly differently based on the genitalia. Embryologically, all of our bodies begin with the exact same anatomy, and that genital ridge begins forming about 8 to 9 weeks gestation. So that differentiation usually is dictated by genetic information on X or Y chromosome. It's usually complete by about 16 weeks gestation, but I think it's important to know that the muscles are the same. They just have different orientation. So then I wanted to talk a little bit about the differences in the pelvis and their anatomy. So if you look, I have these two pictures. The one at the top is the female or assigned female at birth pelvis, and the one below is the male or assigned male at birth pelvis. So when you look at the top, it's inherently less stable simply because of the anatomy. You notice that the hips are set wider apart because of the need for ability to birth a child. You have a wider opening. And then that male pelvis, it is narrower and has less openings. So just noticing some differences there. And then again, just talking about the jobs of the pelvic floor muscles. So we talk a lot about the 5 S's. So stability being your core stability, the sphincter control, sexual function, support, because the pelvic floor muscles are the floor of your core, And then sump pump, which is basically those pelvic floor muscles help to manage the lymph coming from your lower extremities and upwards. And I actually really love this GIF. I stole this from BurrellEducation.com. I show this to patients frequently. So as I mentioned earlier, and as Dr. Hameed also referred to, the pelvic floor is part of a larger system. So when the pelvic floor muscles are functioning optimally, those pelvic floor muscles are working in concert with your abdominal muscles, with your diaphragm, and they're part of this canister that provides our pressure. So in both pelvic health and scoliosis exercise training, we talk a lot about the importance of understanding and using our pressure systems appropriately. So intrathoracic pressure, intra-abdominal pressure, and how to manage those. When we are thinking about maintaining functional pressure systems, we need that appropriate pelvic floor muscle function. And when those pelvic floor muscles aren't functioning optimally, then we can see issues like pain, like constipation, like leaking. So talking a little bit more about pelvic floor dysfunction specifically. So again, Dr. Hameed already talked a bit about this. I tried to break them down into 3 separate categories. For our pediatric colleagues, you're probably not thinking as much about the sexual health proponent here, but I wanted to mention it for anyone who is also treating adults. So you can see bladder issues, urgency to go to the bathroom, leaking, difficulty with stream. You can see bowel issues. You can either see leaking or constipation. You can think of that outlet constipation. If those pelvic floor muscles are too tight, they will be unable to maintain the stool, or sorry, unable to open to allow the stool to come out. You can have some of that pain that surrounds bowel movements, or in adults can surround sexual activity as well. And then you can see sexual health concerns as well. So that can be pain, difficulty with intercourse, inability to tolerate intercourse, pain or irritation of the vulvar region or of the penile region. I also wanted to talk a little bit more about the occult pelvic floor symptoms, which again, Dr. Hameed sort of alluded to already. But this can be that persistent low back or hip pain that you can't address with your orthopedic treatment. This can be symptoms that are worse with chronic sitting. This can feel like pressure or the sensation of a foreign body in the rectum or in the vaginal opening. For our pediatric population, sometimes this can be exercise-induced activity that results in leakage. So this is something that a lot of people don't actually talk a lot about. There is a lot of research in the pelvic health world about how power athletes, such as dancers, gymnasts, pole vaulters, anyone that has a lot of impact, they can actually be experiencing leakage and maybe not even telling anyone about it. But this would be a pelvic floor issue. Often that's due to pelvic floor overactivity. But this is something that we should be kind of screening our patients for. I wanted to highlight this awesome screening tool. This is called the Cozine Pelvic Dysfunction Screen. It was developed by a pelvic PT in California. It's very easy to administer depending on your EMR system. It may already exist as a template. My clinic uses Jane, and this was already accessible to me, so I've just added it into my templates, and I send this to people before their session. It consists of 10 questions. It's sort of just like a tick box, so kind of a yes or no. It inquires about bowel and bladder concerns, pelvic pain, sexual function. And if a patient checks 3 or more statements, they would probably benefit from seeing a local pelvic PT for eval and treatment. So this is just an example. So just some of the common ones. I sometimes have pelvic pain that exceeds a 3 on a 1 to 10 pain scale. I sometimes experience these urinary symptoms: leakage, inability to control bladder, pain or burning with urination, talking about all those different categories. So it's pretty easy if you want to administer it in person. It takes less than 5 minutes, and it's a really great tool to give a good understanding of what could be going on with this person's pelvic floor. Okay, so when to refer to a pelvic floor specialist. Go. So Pelvic floor therapy, again, Dr. Hameed talked about this briefly. So a pelvic floor therapist, this could be a physical therapist, this could be an occupational therapist, but they are trained in evaluating and treating the pelvic floor muscles. So there's a saying that it's like an orthopedic therapist in a cave, but they have training in assessing the pelvic floor muscles specifically. So the assessment may be external, just by palpating externally the pelvic floor muscles to the ability that you can. It could be internal assessment, either intravaginal or intrarectal. And pediatric patients are less likely to participate in an internal assessment. However, for some patients, it may still be indicated. So that's something important to keep in mind. Pelvic therapists, they do a lot of just what you would think of as typical assessments for your just typical orthopedic PT. They're looking at your functional movement strategies. They're looking at how you walk. They're looking at squats. They're looking at all these different things. They're looking into your muscle strength and flexibility, your pelvic floor muscle function and strength. So they will be doing that internal assessment for that. And they might also have you do a log looking at your current symptoms, your current patterns of leaking, what you're experiencing. So patients who are reporting unrelenting pain, bowel or bladder issues such as leaking, being unable to control gas, or difficulty with constipation, they would likely benefit from a pelvic PT or OT assessment. I did want to speak a little bit more about constipation. Dr. Hameed also alluded to this as well. In pelvic PT, we talk about this a lot because constipation can be a big driver in symptoms. We should be asking patients about their poop. You can make it casual. You can make a joke about it. It is very easy to take this Bristol stool chart. You can get it on a little badge buddy that can live on the back of your badge. You can get it as like on the back of a clipboard. You can have it hanging in a treatment room. Constipation is an insidious cause of both low back pain and pelvic pain, as well as leaking, incontinence. So chronic constipation, somebody can actually be pooping every day and still technically be considered constipated. So if you look at this Bristol stool chart, you can see that there's sort of a range. So that type 1 and 2 is usually the much harder to pass, more dry, difficult pebbles that are really hard to evacuate. So people with these types of really hard stools are more likely to have to strain to get the stool out. It can also lead to more pressure if this is chronic, which for a lot of people it is, even starting in childhood. It can create a lot more pressure on the pelvic floor muscles. And actually, in the long term, it can cause more risk of pelvic organ prolapse, particularly for women, particularly postpartum. I did find a stat. I have the link in my references later, but up to 15% of North American adults are constipated. And there's also a high incidence of children who are still bedwetting, that it's related to constipation as well. There's also a large link of the low back pain and even lumbosacral radiculopathy that's related to chronic constipation. So you can always educate. I would ask your patients about their pooping, and I would also make sure that they know what a normal poop is. So we like that type 3, type 4. Think about a sausage, think about easy to pass, and that they're pooping daily. So all of the education I'm sure you're already doing. But I always like to say, assume someone is constipated until it's proven otherwise. Okay, so speaking a little bit specifically about thoracolumbar scoliosis and the pelvic floor. So I just put these two pictures in to kind of think about if you're able to, you can stand up and try to mimic these postures and see if you notice differences in your pelvic floor. But if you think about those pelvic floor muscles, they function in all the kinetic chains. So because of the way they're oriented and because of their function, they have to work in all the different movements. So they have to stabilize us and support our movement in many different positions. And like I alluded to earlier, they should be working when it's optimal with the deepest core muscles to provide support. They're also related a lot to those hip stability muscles. So as Dr. Hameed alluded to earlier, there is a lot of gluteal pelvic floor connection there. When the gluteals are not working appropriately, there's a strong likelihood that that pelvic floor is probably compensating. And just because of, we know just kinematically, scoliosis and kyphosis both can lead to asymmetrical muscle activation, compensations, pelvic obliquities that can definitely impact our pelvic floor function. I'll speak to this a little bit in the next slide, but just kind of alluding to when our rib cage is aligned over the pelvis, our pelvic floor muscles are more aligned to do their jobs. I want to speak a little bit to pelvic floor and kyphosis. So just thinking about our sagittal balance here. So I put the two pictures of the typical spine with a little bit of that gentle S shape versus a spine with kyphosis. So as we know, kyphosis can occur both in the thoracic region and the lumbar region. We know that thoracic kyphosis is physiologic and normal. We can have a hyperkyphosis, but we can also see kyphosis in the lumbar spine, or rather basically a lack of lordosis. The increased thoracic kyphosis causes that rib cage to be shifted posteriorly. So if you think, if you can mimic that, I cannot because my spine is fused, but you can feel within your own body how that changes the forces down through your pelvis, how that changes your weight in your legs, and how that impacts potentially your pelvic floor muscles. There is more research, however, on when we have lumbar kyphosis or that lack of lumbar lordosis and how it relates to creating a relative retroversion of the pelvis, which causes gripping of the pelvic floor muscles and also more changes down the leg. Usually we can have a hip flexion or a knee flexion. We can have hip extension. We can see all kinds of compensations because of that change in the structure of the spine and the sagittal plane. So a little bit about pelvic floor and scoliosis. Again, there's not a lot of research on how scoliosis impacts the pelvic floor, but we can just think about how the torsion of the spine is impacting the pelvis. So due to the limited amount of time that I have, I'll avoid the complexity of the topic and just defer to that statement, but just knowing that because we have the scoliosis, which is causing shifting and rotation of parts of our spines from, one curve up to 3 separate curves, we can imagine how it might cause compensations within the pelvic region. So it's also important to remember that the pelvis is comprised of 3 separate bones, which can experience torsion within themselves. So the pelvis is not actually a block. The pelvis is made of different bones that can most certainly be impacted by torsion anywhere in the system. And as we all know, that torsion impacts the entire body and not just the spine. Okay, so finishing up here, I did want to do a little bit of talking into the research that's currently available. As I mentioned, there's just not a lot. Perhaps Columbia will help my pelvic colleagues and myself spearhead future research into this topic. It's important to note that, so I talked a little bit about how pelvic floor dysfunction does appear to be linked with changes in the lower regions of the spine. There's these 2 studies that talk specifically about sagittal spine changes. So looking at that first study from 2000, Maddox et al. Found that women with loss of lumbar lordosis or kyphotization of the lumbar spine had a higher risk of pelvic organ prolapse compared to the average population. They didn't speak necessarily into the mechanics of that, but I would imagine just because of the forces throughout the pelvis. And then there was another study that looked more at the alignment of the sagittal plane and whether someone experienced symptoms. Now, in this study, they did not find there was a significant association of symptoms with structural changes in the sagittal plane. One thing that I wanted to note that I have not specifically discussed earlier, but Dr. Hameed also sort of alluded to. It's important to note that somebody can be experiencing pelvic floor dysfunction without overt symptoms. So that can look like unexplained urinary urgency. That can look like constipation. That can look like low back pain, pelvic pain, hip pain that may have been misdiagnosed as an other orthopedic issue. So just things to think about. And then lastly, the one study that I could find that spoke a little bit to scoliosis and pelvic floor dysfunction from 2012. There was a reported link between idiopathic scoliosis and pelvic floor dysfunction, but they said more research is needed, which is a common phrase that we find in research. And it concluded that providers treating scoliosis should be aware of the possibility of coexisting pelvic floor disorders. So essentially, we need more research. We need more research in this area, but there is definitely a link. There's a link to potential of dysfunction within within the pelvic floor. When we have scoliosis, we should most certainly be screening for pelvic floor dysfunction. There are some easy tools to use. And I can send a link to Pelvic Guru is a nice directory for pelvic floor providers as well. And then there are my references. And that's it.
Thank you so much, Laura. I wish we had days more to pick your brain on all you've experienced. And I'm sure lots of people will be reaching out to you to ask some questions. Dr. Hameed, I want to make sure we save some time for some medical interventions. So take it away, Dr. Hameed.
All right, thank you. So as I alluded to, we're going to sort of talk now a little bit, switching gears, about some of the management options that we have available for, pelvic pain. I will sort of give a caveat that I don't always do a lot of these interventions. I have great pain management colleagues that I will send to for these, but I can happily talk through this. So we'll talk a little bit about when we think about chronic pelvic pain. I think I alluded to a little bit, right? There's different sort of sources, right? There is more of somatic myofascial, sort of pain. So from the musculoskeletal system specifically. But then, of course, we have that visceral, either GU or gynecologic or a GI sort of potential pain generators. And then, like I also talked about, we have some of these nerves that live very close by all of these structures. And so you can get neuropathic pain. So I think when we're thinking about treating that, we have to kind of in our minds split and sort of think about that. There is absolutely overlap as well. So I don't just make it like separate buckets. But I think in terms of just speaking about these medication or treatment options that are available, I think splitting it up can be helpful. I'll talk a little bit about medications as well as interventional treatments. So I sort of alluded to these different etiologies. First line, physical therapy. We've already heard from Laura today about just how important the physical therapy aspect is, thinking about all these different sort of pieces of improving alignment, improving sort of the ability for those muscles to even know that they exist, and then how to fire them and how to support you in all these different movement patterns and things that we rely on throughout the day. So physical therapy, huge, huge, huge first line treatment, and really the main sort of stay of treatment, but sometimes that's not enough. And so there are other things that we'll sometimes do for this. So medication wise, sometimes it's just topical sorts of medications, whether it's lidocaine or sort of suppositories of sort of muscle relaxants, so either Valium or baclofen can be delivered. There are also combination sort of anesthetic neuropathic muscle relaxer suppositories. You have to work with really compounding pharmacies for all of those suppositories, but they do exist and they can be very helpful in terms of treating some of these symptoms of the pelvic floor. You can also use sort of oral muscle relaxants. Those can be helpful. Tizanidine and cyclobenzaprine are sort of a couple of different options that might help, as well as neuropathic medication. So whether it's something like gabapentin or Lyrica, or some of the tricyclic antidepressants, or the SNRIs like Cymbalta, for example, these are all different classes of medications that sometimes, especially when pain has been going on for a very long time, it becomes chronic, it becomes unrelenting. Sometimes we do need to intervene with something further other than the therapy. And so these can be helpful tools. For somatic pain syndrome, sort of talking a little bit more about now interventional approaches that we can use. So obviously, somatic pain really coming from the musculoskeletal system, right? Whether that's the SI joint, the spine, the hip, the tailbone, there's a lot of different sort of actual physical structures there. And then, of course, the muscles of the pelvic floor that can lead to sort of pain. And so a lot of the times for that sort of myofascial muscular pain, we do things like potentially trigger point injection. So this can be done with or without medication, generally mostly done with lidocaine, sometimes with steroid, but basically introducing, sort of these needles into these different muscles to try to get a trigger point release, just like we could, in the neck, for example, can be helpful. When you don't get permanent relief, you can actually sometimes also do Botox injections. So just like we will see that for migraines and other things into different muscles around the head and neck. That can be done to the pelvic floor. Obviously, you really want to make sure you're seeing somebody that does a lot of this because, of course, too much Botox, you relax that pelvic floor. Laura already alluded to the importance of those muscles and what they're helping support. So we don't want to overly weaken those muscles, but Botox can be helpful for pain as well. These trigger point injections are generally done via a trumpet. So basically using sort of this long sort of needle here that will be sort of inserted through that trumpet to then get to those areas where our, because obviously these structures are quite deep. And again, studies have shown that they can be very helpful for, sort of pain scores. So very, very useful first line tool. For referred pain, right, because we talked a lot about this overlap, whether it's from the spine, the hip, the SI joint, et cetera. Sometimes targeted injections into those areas, right, those joints or a nerve that's maybe pinched in the spine, for example, can be helpful. And so these are just some pictures of sort of different types of injections that can be done for that. But those are also, potential interventional techniques that we'll use. Now, for more of that visceral pain, right, whether it's gynecological, urological, abdominal, whatever it might be, I think, we have to sort of think about other types of treatments. And so there are some pain interventions. Again, my pain colleagues are the ones I refer to for these. But there are sort of visceral sort of nerve blocks that we can do, whether it's for the ganglion impar block or the superior hypogastric plexus block. These can be helpful for more of these sort of visceral pain conditions. Ganglion impar is also done actually for chronic coccydynia, but this is basically a sort of a block to the sympathetic fibers of the ganglion impar that sort of live here right in front of sort of that sacrococcygeal junction. And that sort of block will sort of block pain to the perineum, the distal rectum, the anus, the urethra, the vulva, and the coccyx potentially. So it can be really helpful for pain in that region. This is generally done under fluoro guidance, and you can sort of see that needle sort of going through that sacrococcygeal junction, going right sort of anterior to that. And that's the contrast that sort of outlined that. There is also potential for, phenol for neurolysis and radiofrequency ablation, which there is sort of a small study that did show that that was helpful. Again, sort of a little bit more interventional and certainly see a pain management person that really does a lot of these, I think, before you sort of go down that path. But obviously, in some cases, it can be really helpful. And so it's sort of important, I think, to just know that it exists. You can also consider doing more of a superior hypogastric plexic block that would actually do a little bit more of the abdominal and pelvic region. And so this is sort of a block that happens sort of, I'll show you where exactly. Here, it's sort of right by actually the abdominal aorta and where it splits. And that will help sometimes with pain higher up, so more uterus, bladder, descending colon, potentially even rectal involvement, but sort of a little bit higher up in terms of its target and where you might get relief from. And so this would be more for like endometriosis, inflammatory bowel disease, post-op adhesions, potentially, gynecologic cancer. And so this is done. Now you can sort of see this is your L5 vertebral body, and it's sort of the needle is directed here anterior to that where that plexus lives. And, whether that's done with a neurolytic block or, steroid or, I hadn't seen anything for radiofrequency ablation for this, but that's another, potential pain reliever. And again, for more of that visceral pain. Now switching gears to more neuropathic pain, so actual sort of peripheral nerves that are getting entrapped. There's a lot of sort of overlap here. I know I sort of showed you the schematic here, but certainly here you can sort of see sort of along the hip and groin region where, some of these nerves and where the entrapment might present. And so for neuropathic pain, that's more burning, shooting, tingling, like pudendal neuralgia, iliohypogastric, ilioinguinal neuralgia, genitofemoral neuralgia, inferior cluneal neuralgia, all of those nerves can be targeted. And so we'll sort of talk quickly about how to do those. So for the pudendal nerve, excuse me, remember there are 3 branches that are there, but generally where we block is going to be sort of proximal to where those nerve branches off. And it can be helpful if you remember sort of here, for pain kind of in this region here around sort of that pudendal nerve area. Can help with bladder pain, anal pain, rectal pain, pelvic floor pain, and perineal pain. And so these are generally done either by fluoro. So this is sort of a picture here of a fluoroscopic guided intervention, or via ultrasound. So this is at the ischial spine, and then this is sort of at Alcock's canal. These are done sort of transgluteal, so you can kind of see here where the ultrasound probe is in relation. And so those are all possibilities in terms of potentially providing this. Obviously, ultrasound is a little bit tricky depending on body habitus and things. So sometimes it's not always available though. What about the ilioinguinal and iliohypogastric nerves? So those are going to be more of that abdominal and groin pain, but they can also help with labial pains, mons pubis pain, and inner thigh pain. And so, sort of blocking here, I'll sort of show you a picture next, via ultrasound is actually generally how this is done. These nerves actually live in between the internal oblique and the transversus abdominis muscle. And so you can sort of see here, right, sort of cephalad to the anterior superior iliac spine, a little bit lateral. You can sort of get those muscle groups and see those little nerves here traveling in between those two muscle groups. This can be helpful for people that might have, pain refractory for hernia repair, appendectomy, C-section scars, surgical incisions in the lower abdomen. Those nerves can get entrapped and it can be helpful. Genitofemoral nerves. So this is sort of more generally more inner groin region. So you can sort of see the genital and sort of femoral branch. So a little bit further medial into the groin region here. And that nerve can be also done either via ultrasound, which is here. You have to be really careful because it's right above sort of the external iliac artery. So we want to be really careful with getting into that nerve with ultrasound, as well as obviously with fluoro here, but that can be done as well under fluoro guidance. Lastly, I'll just quickly talk about neuromodulation. There are a lot of different things that are trying to be done for these chronic pain conditions where you get some relief from a block, where we're just putting a little lidocaine and or steroid, but not really full relief. And so, pudendal nerve stimulation, there's like sort of stimulators that can be placed that can sometimes be helpful for pudendal neuralgia. You could also consider either spinal cord or sacral nerve stimulation, DRG stimulation. So there's a lot of new work being done in the pain space to really look at this and sort of see what treatment options might be available for more of this chronic pelvic pain. More research is going to come out. I'm not going to talk to you in any great detail, but just know that that's on the horizon and potentially might be really life-changing for folks. So that is all I wanted to sort of talk about as a quick, brief overview. I'm going to stop sharing and hopefully we have time for questions.
Thank you so much, Dr. Hameed and Dr. Glazebrook. This was wonderful, and I have a million questions, and unfortunately, we only have time for a couple. I think the larger question I have is because it sparked so much interest is, maybe this is a better question for Laura. What course do you recommend a scoliosis spine PT watching take to learn more, to become certified, even just externally, so we can be better practitioners?
Meaning just like an orthopedic continuing education course?
Yeah.
There are so many options. I think it very much depends on what you are looking for. I actually really enjoyed, there's something called PRI, Postural Restoration Institute. They do a pelvis restoration course that there are things that I don't necessarily agree with from the methodology perspective, but I do really like how they spend a lot of time talking specifically about how the pelvis interacts, like the different muscles, and it does a really good job of discussing the kind of complexities of the pelvic floor and the pelvis. You can also very easily do APTA, Herman and Wallace. They have like a level 1 training, just if you're interested in doing actual internal assessment, which I do feel like for most, I wish there were more of us that were trained both in pelvic floor treatment and scoliosis treatment. I don't think there's a lot of us that do both. If you're interested in learning how to do more of the internal assessment, then Herman and Wallace and the APTA have pelvic specific courses. There's also a number of like IPA, there's different institutes that talk specifically more about the pelvis and how the interaction of just the special tests and things that need to be done to have a better understanding of the pelvic floor muscles. There's there's tons.
Some, I think we only have time for one question. I think the larger question is there's a lot of single practice providers. Maybe someone's coming without a prescription. What are some signs of pelvic prolapse? What are some precautions PTs should be aware of? Like, can we do traction? Like, are there things that are no-go? Like, we should see a doctor right away. I let Dr. Hameed go first if she has anything to say, and then Laura second.
Yeah, I mean, I think Laura gave a nice sort of screening assessment that you can potentially use. So I think really looking for, any symptoms of either, sort of incontinence, retention, in terms of, sort of the GU system, the GI system, constipation, also incontinence there, thinking about sexual function and if there's pain with intercourse or pain after, things like that. So I think those sorts of screenings are probably the most helpful so that you can kind of fully assess the patient and then refer as needed. In terms of no-goes, I can't think of anything that I am aware of. Laura, I don't know if you wanted to speak on that.
Yeah, so normally what I'm listening for is just symptomatology. These would be primarily women or people assigned female at birth that are talking about having pressure within the pelvis. They may feel a heaviness, they may feel a bulge. A lot of times it can actually be asymptomatic, meaning that they just, like one day they're going to the bathroom and they go to wipe and they find that there's something there. I think what, as a profession, what we're trying to do is we're trying to go away from keeping people from doing things. We're trying to empower them that their bodies just maybe need a little more support. A lot of pelvic PTs and similar trained providers can also fit pessaries now, depending on where you are. But I would shy away from giving people limitations on what to do because, as we know, fear of movement can create a whole host of other issues. So if someone is having those symptoms, maybe have them go for a pelvic PT assessment or a urogynecologist who can help them with pessary or other treatment interventions.
Great. Thank you so much, everyone. I hope everyone enjoyed today's Lunch and Learn. I wish we had more time for questions and learning. I hope you guys can join us for the next one on April 7th. Happy New Year and enjoy your day, everyone.
Thank you, everybody.
Thank you.
Thank you.